And welcome back to the Ninja Nerd Podcast. Today we're talking about platelet disorders. We've got a really good episode for you. We've got a lot of cases, 7 cases to be exact, where we're going to try and go through each one like we normally do, break it down, try and dissect each case, and try and hopefully guess what's going on based upon clinical findings, exam findings, and so on.
Yeah, platelet disorders, they're tough, and I think it's important for you to have a strategy to approach them because a lot of the times when you're in the hospital and you see a patient who has thrombocytopenia, it can be daunting and you're not sure what's the next step. What should I do? I think after this, I hope that they'll have a pretty good understanding after this.
Oh, I know they will.
All right, let's do it.
All right, let's get to it then. So case 1, we have a 72-year-old male, presents with new onset calf swelling and redness 2 days after starting heparin therapy for a DVT. The patient reports tenderness and swelling in the left leg. He was admitted to the hospital 5 days ago for a DVT and started on heparin therapy. There has been a significant drop in the patient's platelet count over the past 2 days. There is no history of prior heparin use prior to this administration. For his exam, we have vitals. BP is 130/80, heart rate 95, respiration 18, and his temp is 36.8 Celsius. For his extremities, we have a left leg noted for erythema, warmth, and calf swelling. Skin, no petechiae or purpura. Cardiovascular, regular rate and rhythm, no murmurs. Now for the lab findings, we get back the following: a platelet count of 70,000. Upon initial admission, his platelet count was 210,000. D-dimer elevated. Coagulation studies, normal PT, INR, and PTT. So Zach, a few questions for you, and you guys will kind of notice a theme as we go through this. It's going to be kind of the same questions, but hopefully we can keep breaking it down and dissecting each case.
Yep.
So first question for you, Zach. Based upon this information, what is the cause of this thrombocytopenia, and how does this progress to this point?
So I think whenever you have a patient with thrombocytopenia, the first thing that you should ask is, I think first off, is it severe? Because I think before you even start doing workups for a patient, you should have an understanding of, is there any indications for a platelet transfusion? So oftentimes, for example, if a patient comes in, they have a platelet count of less than 10,000, their risk for spontaneous hemorrhage, especially intracranial hemorrhage, is very high. And so it's really important in those kinds of scenarios that I give the patient a platelet transfusion to get that platelets up. All right, so that's really, really important, I think, to consider. But for this patient, it's about a 70,000, so that's not super concerning. I'm not in one of those scenarios where I'm really, really like, okay, we got to figure this out. We got to get them on treatment right away. But I do need to start getting on top of this pretty quickly. When the platelet count gets to less than 50,000, that's when I might start getting a little bit more nervous, and I need to start kind of considering, do I need to give this patient a platelet transfusion? What's my workup? What's my steps that are going to get started on? But 70,000, I'm not super concerned, but I do need to get onto this really quickly. So first thing is, once I've determined that there is thrombocytopenia, platelet count less than 150,000, the next thing I want to know is there anything on the peripheral blood smear or anything else on the CBC that suggests that the patient could have other findings besides thrombocytopenia? In other words, is it just thrombocytopenia, or is there anemia and thrombocytopenia, or is there pancytopenia? And from their kind of like lab findings, there's nothing that suggests anything else that's pertinent, because I'm assuming this is only pertinent findings. So the platelet count is 70,000. Mm-hmm. There's no mention of their hemoglobin. There's no mention of their white cell count. So I'm assuming those are normal.
They were all normal, correct?
Yeah. So in that scenario, this is an isolated thrombocytopenia. So whenever you have an isolated thrombocytopenia, you should have a couple differentials in mind. I think the first one is ITP. The second one is HIT. And the third one that you can consider is antiphospholipid syndrome.
All right. The first two, what do they mean?
Okay. So yeah, HIT is heparin-induced thrombocytopenia.
Okay.
ITP is idiopathic or immune thrombocytopenia purpura. And then the last one is antiphospholipid syndrome, also sometimes abbreviated APLS. And so those are my three. Okay. I can start thinking about history more often than not to determine the likelihood of one of these. So ITP is a diagnosis of exclusion. In other words, I have to exclude every other condition before I get to ITP for thrombocytopenia. That's tough. So I'm going to say it's less likely that it's ITP, but let me go through my clinical history. The first thing I want to know is, could it be HIT or could it be antiphospholipid syndrome? With antiphospholipid syndrome, you look for a female who usually has a history of like recurrent miscarriages, recurrent thromboses. I don't really see any of that here. First off, this is a 72-year-old male. So the likelihood of a patient having antiphospholipid syndrome in this scenario, low. If I really needed to, I could consider Is there a chance it could be? I really think it's unlikely because antiphospholipid syndrome, usually SLE is in the history, usually female, recurrent miscarriages, recurrent thromboses. I'm going to say the likelihood's low. What I do have concern of is HIT. And so HIT, we use something called the 4T score. And the 4T score, if you guys are out there, utilizing this video, just go into MD Calc and there's literally a button. You just click and you'll go through. And so the first thing is timing. So have they had a drop in their platelet count and they've taken heparin within the past like 5 to 14 days? If they have, that accounts for a certain number of points. Next thing is thrombocytopenia. How rapid was the drop? Usually anything greater than a 50% drop is pretty concerning. So if I see like anywhere between 5 to 15 days that they've taken heparin, there's a greater than 50% drop in their platelet count from their baseline, which in this one, it's definitely greater than 50% drop. And they have evidence of thrombosis. Now here's the thing. They had a DVT. Could have been a DVT prior to this. Probably. They're on heparin therapy for the DVT. It's hard to say, is it the chicken or the egg? I'm going to just say that they probably had a DVT prior to this. And it's not HIT that's driving the thrombosis. But one of the things that happens with HIT is that HIT can increase thrombosis. So what happens is patient gets exposed to heparin. Heparin binds to what's called PF4, which then binds onto the platelet. The platelet becomes activated and sticks to the vessel, and then you get a clot. And that clot, guess what it does? It just keeps consuming platelets. That's how you get the thrombocytopenia. But then if you keep getting these clots, they occur in the veins, and so you can get DVTs, PEs. They can occur in the arteries, so you can get acute limb ischemia, you can get an MI, and you can even get a stroke. So those are the things that I would be looking for here. There is thrombosis. Is it related to the HIT? I don't think so, but I would consider it. And the last thing, is there any alternative causes? I don't think so. So if I have that 4T score and it's pretty high, we say greater than, or at least greater than or equal to 4, I'm highly suspicious for a patient having HIT. So what I would do is I would assume that the patient has heparin-induced thrombocytopenia, and that's due to heparin use. So right away, I'm going to discontinue the heparin, all right? And I'm going to start them on another alternative anticoagulation. Because I'm going to start saying, okay, if I think that this is HIT, what I should do is I should send off some tests. But I can't just send off tests and just let the patient go by. I need to treat them. So I'll stop the anticoagulation, start them on an alternative, and I'll send off 2 tests. First one they usually send off is what's called a PF4 antibodies. You're just testing for the presence of that heparin against the PF4. If that comes back positive, the last test that we order is what's called a serotonin release assay. That's the gold standard. And so what happens is, if a patient has these antibodies and you put them in kind of like a solution of platelets, what will happen is it'll trigger the antibodies to bind to the platelet, and the platelet will release something called serotonin. So if you have the antibodies, it'll activate the platelet, and serotonin levels tend to be higher. If the serotonin's high, that's a positive assay. If the serotonin's low, it's a negative assay, and it's unlikely that they would have HIT. So the gold standard is a serotonin release assay. So that's what I would do. I'd say high 4T score, high likelihood of HIT, get the PF4 antibodies, get the serotonin release assay based upon that result. If it comes back positive, they have HIT. On the other hand, if I did this and their 4T score was less than 4, I'm done. It's not HIT. It's unlikely HIT. Don't send any antibodies. Don't do anything else. It's unlikely HIT. So that's why the 4T score is of significant importance here. That's the way I would go about this one right away.
You mentioned using an alternative anticoagulant. So if you use an alternative anticoagulant, which one would you go for?
So you just have to stay away from anything that's heparin related. So I wouldn't use low molecular weight heparin. I wouldn't use unfractionated heparin. For this one, we would use, they're kind of like alternative, like argatroban. Bivalirudin is an alternative one as well. They're kind of like factor 10A inhibitors, but you only give them like IV. And then I could give fondaparinux. It's like a synthetic type of like factor 10A inhibitor. So those are the alternatives: argatroban, bivalirudin, and another one called fondaparinux. I would do that. And if the patient still has the DVT, I would eventually use those, and then I'd probably bridge them to warfarin for a bit until they finish, and then we actually get rid of that DVT and then discontinue it. But for right now, stay away from the heparin, use an alternative, bridge them to warfarin, and use the warfarin outpatient.
All right. Well, then there's case 1. Let's move on to case 2.
Okay.
We have a 35-year-old female, presents with recurrent miscarriages and a swollen right calf. Kind of sounds like something we just talked about.
Yeah.
The patient has had 3 miscarriages before 10 weeks of gestation. She now reports a swollen and painful right leg over the past 3 days. She has no history of autoimmune disease or prior clots. For her exam, her vitals, BP is 140/90 and a heart rate of 100. For her extremities, we note swollen and erythematous right calf. For her skin, there is no petechiae or purpura. We do some lab findings. We get back a platelet count of 90,000. Our coagulation studies, we have a prolonged PTT. And for our antiphospholipid antibodies, we have positive lupus anticoagulant and anti-cardiolipin antibodies. So Zach, based upon all of these findings, what is the cause of this thrombocytopenia and how does this progress to this point?
So with this one, I think we kind of have a little bit of an answer, right? Where it's a thrombocytopenia. I'd say that it's not very severe. It's kind of minor. Less than 150,000 is, again, what we would define. Mm-hmm. If it's greater than 50, you should be considering it, but you shouldn't be like super, super concerned, but you should get on top of it. Okay. The next thing is I'd say, okay, is it isolated? There's no pertinent labs to suggest that there's any anemia or leukopenia or anything like that. So it is isolated. So then it's ITP, HIT, or antiphospholipid. From there, they just so happen to give us the coagulation study. So funny enough, when you look at coagulation studies for HIT, it's actually normal. And when you look at coagulation studies for antiphospholipid syndrome, it's normal with one exception, and that's the PTT. So there's an anticoagulant, the lupus anticoagulant. And the lupus anticoagulant tends to actually cause like a prolonged PTT for these patients. And we actually do a test. We'll talk about it another time in the hypercoagulable states or the coagulopathies. It's called the Russell Viper venom testing. But we can alter that. But a prolonged PTT in antiphospholipid syndrome is pretty common. But here's what we need in order to make the diagnosis of antiphospholipid syndrome. You need at least one clinical criteria. In other words, they have to have recurrent miscarriages, at least greater than or equal to 3 within that 10 kind of like week portion of their pregnancy. Or you have to have recurrent thromboses, arterial or venous, so DVT, PE, limb ischemia, CAD, stroke, something like that. So you have to at least have one of those clinical criteria plus one laboratory criteria. And so there's 3 antibodies that we test for with antiphospholipid syndrome. One is lupus anticoagulant. Second is anti-cardiolipin antibodies or lipin antibodies. And the third is called anti-beta 2 glycoprotein antibodies. As long as you have at least 2 of those 3 that are positive plus a clinical criteria, you meet the diagnosis of antiphospholipid syndrome. Now, that would be enough. I could also, again, use my history here and say, is there any heparin exposure in the past 5 to 14 or 15 days? Nothing in here is mentioned for heparin. And again, with that being said, I think that the 4T score is likely it's probably not likely. Plus, we weren't given like an initial platelet count to show that there was a drop. True. Again, suggesting a less likelihood of, hit in this clinical vignette. So I'm really going ahead and saying, that this is most likely antiphospholipid syndrome with the antibodies and the clinical criteria that would suggest this.
All right. Sounds good. How about the treatment for APLS and catastrophic APLS?
So that's good. So antiphospholipid syndrome in itself, if you have a mild thrombocytopenia and some thrombosis, it's anticoagulants. That's
which we would have in this case?
Yeah. So you have thrombocytopenia. This patient does have the DVT. So there's the hypercoagulars. Their clinical criteria is the DVT in their right calf. All right. So they have a right DVT or right lower extremity DVT with some thrombocytopenia. For this one, I'm concerned for the antiphospholipid syndrome. Just simple. So anticoagulation would be the best way to go about this one. For catastrophic antiphospholipid syndrome, you have to have at least 3 tissue beds that you take down. In other words, they would have to have thrombocytopenia, which is more severe, plus they would have 3 organ systems that got taken down. So maybe they had a thrombus of the leg, they had a thrombus of the limb, they had a thrombus going to the brain. So they have multi-system organ involvement. At that point, it's catastrophic antiphospholipid syndrome, and that can be fatal. It is rare, but when that happens, anticoagulation, it can be initiated. But the best thing to do for these patients is to do what's called plasma exchange with steroids. So the steroids will suppress those autoantibodies from attacking our our platelets and causing these thrombosis. But we'll also do plasma exchange in the sense the plasma exchange is when you actually take the patient's blood, you're removing those antibodies from the circulation, and then you're exchanging it for normal plasma with their normal proteins and electrolytes. So that's what I would do if it was catastrophic antiphospholipid syndrome.
Yeah, I see what you mean now with catastrophic. At first, I thought in her case, it still sounds horrible.
Yeah.
But if you go to that next level of 3 different areas,
yeah, it can take down a lot of tissue beds. And so if you get at least 3 tissue beds that are taken down, plus a pretty severe thrombocytopenia in a patient with this history, I would be concerned about catastrophic.
And when you say severe thrombocytopenia, you mean something probably less than 50,000?
Yeah. If I'm getting to that point, I'm a little bit more concerned. And that's a very significant consumptive process.
Right. Okay. Well, that was case 2. Let's keep it moving then. Case 3. We have a 65-year-old female. She presents with oozing from IV sites, and she has shortness of breath. The patient was admitted for sepsis due to pneumonia and developed diffuse bleeding from venipuncture sites. She reports worsening confusion and abdominal pain. For her exam, we have vitals of blood pressure 90/60, heart rate 120, temp 39, skin, petechiae and ecchymosis over the trunk. And for her respiratory exam, we hear diffuse crackles bilaterally. For our lab findings, we have a platelet count of 40,000, a PT-INR of 3.5, fibrinogen level of 72, and her D-dimer is elevated. This sounds pretty bad.
Yeah, call the morgue.
Oh my God. Maybe I downplayed it.
Yeah, this is a pretty bad patient.
This is not good.
Very sick. Very, very sick.
So I guess, what's your first initial thought when you see this? For me, it'd be panic. What do you do?
Yeah, this is a sick patient. So obviously there's a lot of different ways of dealing with this, but with this patient, the thrombocytopenia I would now consider to be pretty severe. It's pretty scary. So when I have this severe of a thrombocytopenia, I get concerned about consumptive processes, right? So the immune ones, they can cause pretty severe, like HIT and ITP and antiphospholipid. They can really drop it down, but when I get into these lower numbers, I get kind of pretty concerned. And so when I see oozing from IV sites, that's always a buzzword term, and every student should know this for DIC, all right? The second thing is whenever a patient could have DIC, there's only a couple different reasons it occurs. Severe trauma, so some type of severe traumatic incident. Sepsis is very, very common, which probably in this patient is due to their pneumonia that's causing this sepsis process. And then obstetrical complications. Most often, more than not, is placental abruptions. Because placental abruptions, the amniotic fluid actually gets into the mother's circulation, and then that amniotic fluid contains tissue factor. But basically, in any of these processes, trauma, sepsis, or amniotic fluid that leak from the from a placental abruption, all of those things cause activation of the coagulation cascade. And so imagine you have all of this kind of processes that stimulate your coagulation cascade. All your procoagulants get activated and they form clots all over the body. So you get clots everywhere: brain, kidneys, legs, arms. It doesn't matter. They go all over the place. Mm-hmm. So you get all these microvascular thromboses because you're consuming your clotting proteins. Because you consume your clotting proteins, what happens to the amount? If your liver can't keep up and make enough, and your liver's making some, but you're consuming it so quickly, you have less clotting proteins available to continue to make more clots. And so they start to bleed. So they actually get clots and bleeding, which seems kind of paradoxical.
It does sound a little off.
So that's where they get the oozing, is from that bleeding because they've consumed their clotting proteins.
So basically they start out with just nonstop coagulation, just clots everywhere.
Yep.
But it gets to the point where they deplete that.
They deplete their clotting proteins.
And then comes the bleeding.
And then comes the bleeding.
Man, that's a rough one.
I know. It's terrible. So with this patient, sepsis is probably their trigger. Oozing from the IV sites is due to the bleeding, but they probably have, again, this worsening confusion and abdominal pain. That's probably because of reduced perfusion, whether it's from hypotension because they're a little bit hypotensive, or it's because you're clotting off areas going to the brain, clotting off areas going to the GIT, some mesenteric areas. And then on top of that, look, they're getting bleeding into their skin over the trunk. So they got petechiae and ecchymosis. That's from the thrombocytopenia that's occurring. So they're not able to stop some of those small microvascular bleeding on the trunk. And then diffuse crackles bilaterally is probably a progression of the pneumonia to ARDS. But we're seeing a lot of a DIC picture here. Now, with DIC, what happens with this one is a patient should have thrombocytopenia and anemia. All right. So I would look for, first thing when I see DIC is I'd see thrombocytopenia. I would also see anemia. And if I got a peripheral blood smear, the biggest thing that I'd be looking for is what's called schistocytes. So if I see anemia, thrombocytopenia, and schistocytes on peripheral blood smear, automatically you should think about MAHAs, microangiopathic hemolytic anemias, which consist of DIC, HUS, TTP, and HELP. All right. Once you get to that point and you have MAHA, then you check the coagulation studies. The only one that the coagulation studies will be just off the map abnormal is DIC. So the ones that'll be super abnormal here, as you can see here, their PT-INR is 3.5. That's elevated. Yep. If I were to check their PTT, that's probably also going to be elevated. If I check their D-dimer, that's elevated. And if I check their fibrinogen, that's actually low. Yep. So a platelet count of 40,000 suggests the thrombocytopenia. I would expect this patient has hemolytic anemia with schistocytes on peripheral blood smear. PT-INR elevated because you're consuming the proteins that are in their common pathway and extrinsic pathway. PTT would be elevated. PT-INR would be elevated because you're consuming proteins in their extrinsic pathway and common pathway. PTT would be elevated because you consumed their proteins in their intrinsic and common pathway. Fibrinogen is going to be low because you have less fibrinogen because you're converting it into fibrin to make the clots. And the D-dimer is always elevated in areas of clot formation.
Sure.
So this really suggests a patient having a DIC.
And then you said DIC, the main reasons why we have this is infection, trauma,
obstetrical complications, and usually placental abruption.
Okay. How about anything with like malignancy?
Malignancy can be a trigger. Yeah, we can actually see this in a rare type of leukemia. It's called acute promyelocytic leukemia, or APL. So that is another one that you can see a type of DIC.
And it just, again, the effects are disastrous.
Yeah, it's terrible.
Well, we've determined that this is really bad. How do we fix it? What do we do to treat this type of condition?
Well, it's always about treating the underlying disease for DIC, and everything else is supportive. So treating the sepsis, getting them on broad spectrum antibiotics, supporting their blood pressure with fluids and vasopressors,
which this patient can definitely use.
Yeah,
90/60 we have.
Yeah. So I give them a little bit of fluids if they can tolerate it, and then put them on vasopressors if they're not meeting the like a good MAP goal. But the big thing is just treating supportive things for the hematological standpoint. So INR is 3.5. Ideally, if they are bleeding still, I'd want to get that INR less than 1.6. So I'd probably give some FFP. The fibrinogen is 72, so they have some hypofibrinogenemia, which can also contribute to bleeding. So I'd probably give them some cryoprecipitate. And then if their hemoglobin was low, let's just pretend it was like 5.2 or something like that, I would give them maybe 2 units of packed red cells to get their actual hemoglobin up. But oftentimes we say, oh, do we give platelets? And platelets, transfusions, they're only really indicated in a couple different scenarios, which we talked about in the transfusion video or in that podcast, but it's less than 50,000 if they're actively bleeding or they're getting ready to get a procedure. Another scenario would be if they have platelets less than 100,000 and they're getting a neurosurgical procedure, or they have CNS bleeding, and then less than 10,000 as a preventative measure to prevent spontaneous intracranial hemorrhage.
Well, she's definitely below the 50,000.
Yeah, and so you got to be careful, and that's the only thing I would consider it, but I would wait more for and I know this sounds terrible, I'd wait for more life-threatening bleeding. So I wouldn't want, the reason why is in DIC is if I give them platelets, they could consume the platelets, worsen their microvascular thrombosis, and then they can actually cause more harm. So I got to be careful, and sometimes we'll wait for DIC. We'll actually push to maybe get it to like 20,000 or 10,000 before we transfuse them with platelets. But this is one of those exceptions where like the DIC, TTP, HUS, things like that, you should be careful giving platelets because you increase the risk of furthering their consumption of the platelets and making more thromboses. So that's the only downside of it.
So just being a little bit more cautious with it.
Yeah, exactly.
Okay. All right, well, let's move on to case 4 then.
Okay.
So we have a younger patient. We have a 7-year-old male, presents with bloody diarrhea and decreased urine output. The patient experienced abdominal cramping and bloody diarrhea for 3 days after eating undercooked meat. The parents report decreased urination and lethargy of their child. For the patient's vitals, BP is 140/85, heart rate 110. Skin is paler and petechiae, and abdomen is diffuse tenderness and without guarding. For the lab findings, we have a platelet count of 50,000, LDH is elevated, creatinine is 3.2, peripheral blood smear is showing schistocytes. So what do we got going on here, Zach? What's the cause of this particular thrombocytopenia?
So again, we don't have the listed hemoglobin, but I would suspect it's low because again, and I can have other features here, but LDH elevated, that's always like a little telltale sign of potentially hemolysis, especially if you combine it with a low haptoglobin. So if I had an increased LDH and a decreased haptoglobin, that would suggest hemolysis, and I would actually see that in DIC as well. So if I were to get hemolytic labs, I'd probably see an elevated LDH, a decreased haptoglobin, increased bilirubin, and DIC. But you're also going to see it in this disease here, which we're going to talk about. The other thing is schistocytes. Schistocytes always suggest a hemolytic type of anemia process. So I have a thrombocytopenia, platelet count of 50,000, and I have a hemolytic anemia. So my differentials are DIC, TTP, HUS. Those are the big ones. And you can consider HELP as well. So for this, I'm already thinking, okay, it's one of those. What would I do next? Well, I could get coagulation studies if I wanted, but in this scenario, I'm going to bet you they'd all come back positive. And the reason why is whenever you see a young child who just had gastroenteritis, some bloody diarrhea, and all of a sudden they develop hemolytic anemia, thrombocytopenia, and renal failure. So look at the patient. They got decreased urine output.
Yeah, creatinine's bumped up.
3.2. You shouldn't have a 3.2 creatinine for a 7-year-old kid, right?
No.
So this is classic of hemolytic uremic syndrome. I could get the coagulation studies, but they'd probably come back completely normal. But I would do it just to confirm. And if those came back normal, I would have a high degree of suspicion that this patient has HUS, hemolytic uremic syndrome.
So being that it was probably from a source like gastroenteritis, what would be that source?
It's usually some type of Shiga toxin. So Shiga toxin is usually found in Shigella, which is in undercooked meats, and then sometimes in travelers. But the other one is, it's called EHEC, enterohemorrhagic E. coli, or sometimes if you want to sound cool, E. coli 0157H7.
Wow.
Yeah. But it's usually something that we can see in undercooked meats. You usually see these as kind of like breakout, like these kind of like problems where food trucks or areas where these are kind of like common like areas where it can cause problems. But usually Shiga toxin is the cause, so they consume some undercooked meat that has those pathogens. Those pathogens damage the intestinal lining. The Shiga toxin gets into the bloodstream, activates the platelets, and the platelets go and actually cause thrombosis to occur. So they form a platelet plug, thrombosis occurs, and it occurs, funny enough, in the glomerular capillaries, and that's why you get the AKI. And then you consume the platelets to make the clot, and then you rip up the red blood cells as they move through that glomeruli.
So how do we treat the HUS?
So with this patient, I would just keep continuously watching their renal function. If you think about it, this is usually it's an intrarenal AKI. So you can give IV fluids, but just be careful that you don't give them too much. If their urine output is kind of really, really declining, be careful, because if you give them too much fluid and they can't get rid of it, they're at risk for volume overload. So give them a little bit of IV fluids. This is a young patient. I would give them some, keep those kidneys kind of trying to work. The other thing is I would keep a very, very close eye on their electrolytes, keep an eye on the potassium, keep an eye on their urea, and look for any pericarditis, encephalopathy, bleeding that can occur sometimes from this. And then I would also watch for acidosis, and then any volume overload. If any of those scenarios come up, especially if they're refractory to me giving therapies, like if a patient's overloaded, I give them maybe furosemide. If they're hyperkalemic, I give them calcium if they have EKG changes and give them furosemide to get rid of the potassium. If they're acidotic, maybe I can give them some bicarb. But if I give them all these things, or they develop uremic encephalopathy, pericarditis, bleeding, dialysis is the best way to go.
Would you consider our patient here to be severe or not quite yet?
I would say that they're right on the brink.
Okay.
Yeah, and I think with this being said, one of the ways that you can prevent them from getting worse is do not give them antibiotics. I know that sounds weird.
Don't.
Do not give them antibiotics. Do not give them any, like, if they're having diarrhea, what would be sometimes your natural reaction? You're tired of like having a punami in your pants, right? So what would you do?
Stop it from punamiing.
Yeah. So you take like an anti-diarrheal or something like that, like loperamide.
Constipate it.
Yeah. If you do that, you just keep the bacteria in the GIT. They cause more damage, more Shiga toxin release. You give them an antibiotic, it breaks the E. coli or the Shigella up, more Shiga toxin. And so you can worsen their condition.
You got to let it just happen, huh?
Let them clear that pathogen out, actually.
All right. Makes sense.
Yeah, that one's an interesting one.
All right. Well, let's go on to case 5 then. We have a 45-year-old female presents with altered mental status and a petechial rash. The patient developed a headache and confusion 2 days ago. She also reports easy bruising and mild abdominal pain. For her exam, vitals, BP is 130 over 85. Heart rate is 95. Skin, we notice petechiae over the extremities. And for her neuro exam, we have a disorientation and there is no focal deficits. For her lab findings, we have a platelet count of 30,000. LDH is elevated, and we have a peripheral blood smear, and we note schistocytes. Sounds familiar like last case.
Yep. Yeah.
So we have to try and break it down again.
Yeah, exactly. It's the same thing. So you got thrombocytopenia. This one's pretty severe. I'm definitely getting nervous about this one.
Oh, yeah.
The other thing is, again, you want to know, is it isolated or is it combined with something else? All the other kind of tests, well, like for example, the first one we had with HIT and antiphospholipid, they didn't mention a anemia factor. They didn't mention any white cell lines, and they didn't even mention anything about other factors like this one does, LDH and schistocytes. But for DIC, for HUS, and for this one, I see schistocytes. I see an elevated LDH. And I would assume if I got that CBC and it showed me the hemoglobin, I'd just see a low hemoglobin as well. So this is a thrombocytopenia and an anemia, and it's a hemolytic type of anemia. So that's your MAHAs. So far we did DIC. Next one is HUS, which we already covered. TTP. So,
and what is TTP?
So that is thrombotic thrombocytopenic purpura.
All these are mouthfuls.
I know, man. That's why everybody always abbreviates them.
I would too.
Yeah.
I get it now.
Yeah. And then there is HELP. Now, HELP, I would see a female that's pregnant.
Right.
So they're likely pregnant in the second, third trimester. That's not mentioned here. Unlikely HELP. I'm going to start thinking it's TTP.
Okay.
But at this point, I know it's a type of MAHA. The way that we determine TTP from other types of MAHAs is, remember the mnemonic, and forgive me, Kristen, who's also helping with it, she's a nurse, but we remember the mnemonic FAT RN. Okay, so it's fever, anemia, thrombocytopenia, renal failure, and neurological symptoms.
Hey, whatever works.
I know. All right, so they call it the TTP pentad. And so here I have thrombocytopenia. We don't have it directly, but the case tried to trick us a little bit and give us the elevated LDH, the schistocytes that suggest hemolytic anemia. We don't have a temperature, but again, fever is one of those. Renal failure would be another one. Creatinine would be elevated, but the biggest thing that really helps to kind of like give it away is the presence of neurological symptoms.
I was just going to say, this patient is confused. So we're having some encephalopathy.
Yeah, and so usually what happens is in TTP, it could be a lot of different reasons why. Oftentimes the patient develops autoantibodies that attack an enzyme called ADAMTS13. And this enzyme is responsible for basically breaking down von Willebrand factor multimers. Because the reason why is if the von Willebrand factor multimers form, what they do is they basically cause platelets to kind of stick with one another and form clots. And so if I get these antibodies and they decrease the ADAMTS13, I can't break down the multimers. And so they start kind of sticking with platelets and cause clots to form. And so the best thing for this kind of scenario here is I probably have some clots that are forming in the cerebral circulation. And usually it can cause stroke-like appearances, so it can cause focal deficits. It can cause seizures, but oftentimes more than not, it causes like some encephalopathy, like you stated. It's like some confusion or changes in their mental status and behavior. So I have a pretty strong suspicion that this patient probably has TTP.
What would you consider being the gold standard that you would say, I'm using this diagnostic tool for this type of patient?
Yeah, so you never want to have to wait for it. If you have a strong suspicion of TTP, you treat. But while I'm treating them, I'm going to send off that ADAMTS13 level assay. And so I'll send that off and I'll start treating them and I'll wait for that level to come back. And if the level's really, really low, it highly suggests the presence of TTP.
So that test would take some time.
It takes, probably about couple days to a week.
Oh, wow.
Yeah.
Okay. Yeah. Please, maybe don't wait.
Nope. That's why. Yeah, same thing with
this
HIT.
Poor patient.
That's why, for example, if your patient has HIT, heparin-induced thrombocytopenia, you stop the heparin, you put them on an alternative anticoagulant, and then if you really do think if that hit that 4T score, it's elevated, you send the antibodies. If I send the PF4 antibodies and the serotonin release assay, it takes a week. So if a patient has HIT and I just stop their anticoagulant and I don't do anything about it, I'm not helping them, and I'm waiting a long time for them to continue to get worse.
Oh, that patient's already discharged at this point. By the time you get that test back, they're home.
Yeah, so it's always important with HIT and with TTP. before you determine a definitive diagnosis, if you have a high degree of suspicion, treat. So in HIT, you discontinue the heparin and start an alternative.
Right.
For TTP, you start Plex and corticosteroids and send off the assay and wait for that to come back, but keep treating them in the interim.
So we're doing plasmapheresis, corticosteroids.
Yeah, that's usually first line in these patients. Yep.
How about the low platelet count? Would we not do the platelet transfusion?
No.
Like you said, they're going to consume it too much?
Yeah, so you can actually you can paradoxically drop their platelet count. So say you give them a unit of platelets, let's say it was 30,000, sometimes you can actually drop.
Wow.
Because you can consume their platelets and then propagate more thrombosis, a little bit more. So you can worsen their thrombosis, so you could worsen their renal failure, worsen their neurological symptoms, worsen their anemia, potentially worsen their thrombocytopenia. And so it's just one of those things that don't propagate thrombosis in this scenario. Like DIC, don't do it. HUS, be careful, don't do it. TTP, be careful, probably don't do it. Really, when you should transfuse of platelets and a patient who has MAHA, DIC, HUS, and TTP is if they're literally exsanguinating, they are severe bleeding, or their platelet count's less than 10,000. Those are really the times when you should try and do your best to avoid giving it.
Gotcha.
If you do give it, let's say that you give TTP, you give them platelets, make sure that you do Plex and corticosteroids first and then give them the platelet transfusion.
Otherwise, there's no point.
Yeah, because you're just going to consume all that. Same thing with like when we treat patients with ITP. If you give them platelets, they'll probably just consume the platelets. But if you give them IVIG or corticosteroids prior to giving them the platelet transfusion, you may help them to keep those platelets hanging.
It's pretty crazy.
Yeah, exactly.
All right, case 6. We're moving right along here.
Yep.
The next one, we have a 25-year-old female presents with heavy menstrual bleeding and frequent nosebleeds. The patient reports a lifelong history of easy bruising and prolonged bleeding after minor cuts. For her exam, we have vitals of BP 120/80, heart rate is 85. Her skin, we note petechiae and ecchymosis, and we have no splenomegaly present. So overall, pretty normal exam, except for the skin abnormalities.
Yep.
And for the lab findings, her platelet count is normal, bleeding time is prolonged, and we do a ristocetin cofactor assay, which is reduced. What on earth is that?
We don't do these a lot, but when I have a patient who has superficial bleeding and sometimes even a little bit of deeper bleeding, so superficial bleeding is like petechiae, purpura, and so those are basically like little dots, like little bruises basically that don't blanch when you push down on them. Mm-hmm. You can get that. You can get epistaxis, which is your nosebleeds. You can get menorrhagia, which is the heavy menstrual bleeding. And sometimes bleeding after like minor cuts or surgeries are pretty common. So when I see that and the platelet count's normal, I definitely my brain starts thinking, could it be platelet dysfunction? The only way that you can really determine this, and we don't do this test a lot as well, but we check bleeding times. I'm not even kidding. You make a long little nick on their skin and you see how long does it take for them to bleed.
Oh, good.
Yeah.
Let me nick up my patient here.
Yeah, exactly. So you'll make like a little nick and you'll determine how long it takes for them to clot. And so if a patient has a prolonged bleeding time, a normal platelet count, and evidence of like some superficial bleeding, you should think about, potentially some platelet dysfunction. The other thing is if I have a family history or a lifelong history of these things, that really makes me think about an inherited type of platelet dysfunction. And so there's a couple of them. One is called Bernard-Solier syndrome. Really, really rare one. You get tested on it maybe sometimes in your step 1, but it's where you have an inherited disorder that you don't express what's called GP1B, which is a type of glycoprotein that basically binds von Willebrand factor to your endothelium. So it helps with platelet plugs, essentially, right? And so if you don't have that protein, you don't allow for your platelets to bind with von Willebrand factor and form a platelet plug. And so that's how you can increase your risk of bleeding. Another one is called Glanzmann thrombasthenia, and that one's also pretty rare, but it's an inherited disorder where you don't express a protein called GP2B3A. I know, right?
Just keeps getting better.
Yeah, they're proteins on the platelets that cross-link with fibrinogen, and so they help the platelets to stick to one another and to aggregate. Okay. And so if you don't have that protein, you can't cross-link the fibrinogen between the platelets, and you can't form a good platelet plug. And so again, they're at risk of not being able to clot, and they bleed. The next one's called von Willebrand's disease. Von Willebrand's disease is basically an inherited disorder where you don't express. There's 3 levels. There's level 1, where you produce a reduced amount of von Willebrand factor. 2, where you produce, or type 2, where you produce a normal but dysfunctional von Willebrand factor. And then type 3, where you produce no von Willebrand factor. And then sometimes, if you look at the textbooks, they'll even say that factor 8, it can go along. So type 1 will say decreased factor 8 and von Willebrand factor. Type 2, you'll have a dysfunctional von Willebrand factor. And in type 3, you'll have no von Willebrand factor or no factor 8. And so it's kind of an interesting one. But either way, in von Willebrand's disease, that problem is you don't have von Willebrand factor. And the von Willebrand factor is supposed to bind the glycoprotein 1b on the platelet to the surface of that actual subendothelium. So if you don't have that protein, you can't bind the platelets and form that adhesion to get a platelet plug. So these are the primary ones. There's only one other one which is acquired, and that's in a uremic platelet dysfunction. Funny enough, we talked about it a little bit with hemolytic uremic syndrome. So if a patient has a really bad acute kidney injury or chronic kidney disease, what happens is they get really bad uremia, their BUN. Probably when it gets up to around 100 or higher, uremic toxins build up, and they can actually block the platelets from adhering to the area where the injury is in the blood vessel to form a clot. They block platelets from being able to stick with one another, and they block the platelets from secreting ADP and serotonin, which signals other platelets to come in to form that platelet plug. So that's the 4 different types of differentials that you should have in mind. First thing, look for this patient. Do they have any AKI or CKD? That's the first thing off the history that I would look at. I don't see any of it. So it's unlikely. So UPD, or uremic platelet dysfunction, is a clinical diagnosis. It's the presence of bleeding with a normal platelet count, an increased bleeding time, and the presence of underlying severe kidney disease. So that one's out. So I'm left with Bernard-Solier, I'm left with Glanzmann thrombasthenia, and I'm left with von Willebrand's disease. So what you do is you do the ristocetin cofactor assay, which you asked me about, and I've been talking forever. I'm sorry.
That's okay.
It's basically a molecule that helps to imagine it increasing the binding of von Willebrand factor and GP1B. So there's 2 diseases that were affected by this. So if you have ristocetin, it binds and helps to increase the connection between von Willebrand factor and GP1B. What if you have a disease where you don't have von Willebrand factor or you don't have GP1B? That won't be able to allow for that connection, and the platelets won't adhere and form a plug. That would be von Willebrand's disease, and that would be Bernard-Solier syndrome. This ristocetin cofactor assay would have no effect on the GP2B3A proteins, which we see in Glanzmann. So Glanzmann thrombasthenia would have a normal ristocetin cofactor assay, and von Willebrand's disease and Bernard-Solier would have a decreased ristocetin cofactor assay. From there, I would just check the von Willebrand factor levels, and I would even consider checking what's called a flow cytometry on the GP1B levels on the platelets. If the flow cytometry came back normal and the von Willebrand factor levels and the factor 8 levels came back low, it's von Willebrand's. If the flow cytometry on the platelet showed a decrease in GP1B, then it's Bernard-Solier. I'm going to go ahead and go out on a limb and say that if we did those tests, it's probably going to be more likely von Willebrand, because that's way more common than Bernard-Solier syndrome. And that's the way that I would be able to kind of determine that.
All right, well, how about the treatment of von Willebrand disease?
So von Willebrand's disease is really, you're just replacing von Willebrand factor, right? But funny enough, what we do is if a patient has like some mild bleeding, just a little bit, we may consider something like DDAVP. So DDAVP is actually desmopressin.
Okay.
That's ADH essentially. And it goes to the platelets, hits the receptor on the platelets, and increases the production of von Willebrand factor. So then it'll help you to bind the GP1B on the platelets and help to form a platelet plug. So I would do that in mild bleeding, but if a patient has moderate to severe bleeding, I would go with what's called von Willebrand factor concentrate, which actually contains a little bit of factor 8 in it. And that would be the way that I would go in this scenario, is I would give them, if a patient has good bleeding, good amount of bleeding, or they're getting ready to get a surgery, I would give them von Willebrand factor concentrate with the factor 8 concentrate. And that'll basically replace what they're either deficient in or have nothing of. So if they have type 1, they would have a deficiency. If they have type 3, they have no von Willebrand factor or factor 8, and I would just replace that. Worst case scenario, if we have none of these things, we give cryo. So cryoprecipitate. That's the only other thing that we would give in scenarios where none of this stuff was available, which is not too common.
Okay. All right, well then let's wrap it up with case 7. We have a 35-year-old female presents with a history of easy bruising and heavy menstrual bleeding for the past 3 months. The patient reports noticing small, pinpoint red spots on her legs and recurrent nosebleeds lasting longer than usual. She denies fever, weight loss, joint pain, recent infections, no history of drug use or significant family history of bleeding disorders. So for her exam, we do her vitals. Blood pressure is 125 over 80, heart rate is 88, and her temp is 37 Celsius. Her skin, we note petechiae on the lower extremities and ecchymosis on her arms. There is no lymphadenopathy or hepatosplenomegaly present, and for her cardiovascular and respiratory exams are normal. Our lab findings, we get back the following: platelet count of 18,000, hemoglobin of 12.8, white blood cell count of 6,200, PT-INR is normal, PTT is normal, peripheral smear, there is no schistocytes or other abnormalities, ANA is negative, direct Coombs test is negative. Besides her platelet count, this girl's good.
Yeah, exactly. Yeah. So
it's pretty much negative.
Yeah, and that's usually what happens when you think about a condition like ITP. So they'll try to set you up on the vignette with that, where you have a patient who comes in with thrombocytopenia and no other cell lines are affected in this one, right? So we talked about how in anemia and thrombocytopenia, that was your MAHAs, your DIC, HUS, TTP, and HELP, all right? If it was isolated thrombocytopenia, that was APLS, which is your antiphospholipid syndrome. That was your HIT, and then it'd be ITP, all right? There is one other condition that you could think about, because when we think about platelet disorders, the framework I like to think about in my head is it's either you decrease platelet production, increase platelet destruction, or splenic sequestration. So in certain scenarios, we've talked pretty much on all of these about destruction or consumption. There is times when it could be due to a decreased platelet production. So aplastic anemia, which we've talked about a ton in the normocytic anemia lecture. So in normocytic anemia, we said that in aplastic anemia, the bone marrow fails and they don't produce red cells, white cells, and platelets. So if I ever looked and I saw a patient who had pancytopenia, I would think about aplastic anemia being a potential cause. If I see anemia and thrombocytopenia, I think about MAHAs. If I see isolated thrombocytopenia, I think about ITP, antiphospholipid, and HIT. The one other one, so I said decreased platelet production, increased platelet destruction, are your sequestering platelets. The only time I think about splenic sequestration is a big one of the vignettes is cirrhosis. So in patients who have chronic liver disease, especially if they have portal hypertension, blood backs up into the splenic vein and it causes the spleen to get bigger and bigger and bigger. So it has more vascular spaces to trap platelets and to trap red blood cells. So if I had anemia and thrombocytopenia and there was no evidence of schistocytes, I would be looking at their history to see if there's cirrhosis, because if there's cirrhosis and splenomegaly, I could think about splenic sequestration. But oftentimes when we talk about thrombocytopenia, we focus most of our energy and time in the destruction causes, and if it's immune mediated or non-immune mediated. But again, don't forget, listeners out there, that again, if you see pancytopenia, that could be a cause of thrombocytopenia, but it's an aplastic anemia cause, right? All cell lines affected. Anemia, thrombocytopenia, you think about MAHA or splenic sequestration. Big way to differentiate: schistocytes, MAHA; no schistocytes and splenomegaly, splenic sequestration. So those are the big things to think about here. With this patient, I see isolated thrombocytopenia. So it's not aplastic, it's not MAHA, it's not splenic sequestration. I'm between HIT, ITP, and antiphospholipid syndrome. With HIT, there's heparin exposure. With antiphospholipid syndrome, usually there's thromboses for both HIT and antiphospholipid syndrome. But with antiphospholipid, there's a female who usually has a recurrent history of miscarriages or lots of thromboses that occur. There's no evidence of thrombosis anywhere in this history at all. ITP does not cause thrombosis. That's really, really important. What actually happens in ITP is you produce antibodies against GP2B3A, binds to the platelets, tags them, and they go to the spleen. And the spleen actually starts kind of destroying those platelets. So there should be no real effect on thrombosis here. So if there's no evidence of thrombosis, and I've ruled out, so let's say I rule out HIT. I check my 4T score, it's low. All right, it's not HIT. I don't see anything that concerns me for antiphospholipid syndrome. It's probably not that. I'm not going to even waste my time going and checking into that. So what I would say here is, given that, the next thing I have a suspicion of is ITP, but I need to know if it's secondary or if it's primary. So then I would check things like ANA. I'd look to see if there's any evidence of SLE. I would even add on to this, check HIV, check hepatitis C, assess for any evidence of malignancy, assess for any autoimmune conditions via the direct Coombs test. If my ANA is negative, my hepatitis C, my HIV is negative, all my testing comes back negative. There's no drugs that I see in their history that suggest that this could be the cause, no malignancy like CLL, it's probably primary ITP. If there's drugs, malignancy, or any other kind of autoimmune process, you cannot say with definitive conclusion that this is primary ITP. It's probably secondary. And then you have to treat that underlying cause. For this patient, I'm going to go on a limb and say that it's most likely primary ITP because there's no drugs, no malignancy, no SLE via the negative ANA. And again, I would check the infectious profile, hepatitis and HIV. And if that came back negative, this is probably primary ITP.
Just because it's such a disease, a diagnosis of exclusion, there's really no gold standard test.
Nope.
It's literally going down the list, like you said, and checking them all off.
Yeah, that's the basic thing of what you have to go through with this one.
So then what do you do for the treatment of this disease?
So you have to look at the platelet count. So we talked a lot before about how with most of these conditions, like DIC, it's supportive, HUS, it's supportive, TTP, Plex, and steroids, right? For HIT, get rid of the anticoagulant, give an alternative instead of heparin. Antiphospholipid, anticoagulant. If it's catastrophic, Plex, steroids. For this scenario here, with ITP, we look at the platelet count. If it's less than 30,000, we treat. Greater than 30,000, we don't do shat. All right, you leave it alone and you just keep an eye on it.
So for our patient here, we're definitely going to have to treat. She's low.
Yep. So if it's greater than 30,000, you just keep an eye on it. You don't do anything and you look to see if it gets worse. Oftentimes, the reason why we observe is most of the cases, they get better.
Okay.
And you don't have to do anything. But if it's less than 30,000, we got to do something. So since it is less than 30,000, I would start corticosteroids. If we needed to get this up rapidly, so let's say that the patient was bleeding a lot, which she is bleeding a lot.
For the most part,
yeah.
From her history, sure.
I would even consider IVIG. So the question always comes up, which one do we give, corticosteroids or IVIG? You can give both, but oftentimes corticosteroids is going to be a good one first line that you can start. IVIG would be a one that you can give if you want to rapidly increase their platelet count, because IVIG is going to tie up a lot of these kinds of like antibodies that are kind of going against the platelets. So it's going to tie up those antibodies that are going against the GP2B3A proteins on the platelet. It also tells the macrophages in the spleen, it actually binds onto the macrophages and tells them to stop eating up the platelets too. And so IVIG will rapidly increase the platelet count, whereas corticosteroids may be a little bit slower. But either one of those are a good choice. I would say if you want to give them a platelet transfusion though, IVIG would be the first one to go. But corticosteroids, IVIG would be the first thing, and then I would look. I would say, okay, how long does it take? Usually IVIG is quick. Corticosteroids may take a little bit of time. So I keep a close eye on it, and I'd expect to take a little bit of time for the platelets to go up. If I check after that and the platelets are still low, then I would have to go to my next step. Next step is where I would consider alternative agents like rituximab, which is like a certain type of cluster differentiation protein inhibitor. So it basically shuts down B cells from being able to produce antibodies. Or TPO receptor agonists like ramiplostim. This one's actually cool. I like this one because what it does is you give this drug, it goes to your bone marrow and tells your bone marrow to undergo thrombopoiesis, make more platelets. And so it's kind of cool if you're kind of using this drug as an alternative. So you could have them on steroids or IVIG, and if their platelet count's still low, rituximab or TPO receptor antagonist, add that on. Because what the TPO receptor antagonist will do is while the steroids or the IVIG is working, it'll tell the bone marrow to produce platelets. And so that's kind of cool to do that. I'd say if you do that, so let's say that you have them on steroids or IVIG, you've gotten to the point where the platelets aren't any better, so you have them on ramiplostim, and after 12 months, their platelet count's still low. Their thrombocytopenic resistance for more than a year, we take the spleen out because the spleen's the source of where you're chewing up the platelets. And if you get rid of it, you help to prevent that. So that's the way we would oftentimes treat these patients.
No, we don't need a spleen, right?
Yeah.
Take that thing out.
Yeah, who cares about that thing?
All right. Well, that was case 7, and that was all the cases for platelet disorders.
That was a monster though, right?
It was a monster.
You can see why thrombocytopenia and platelet disorders in general can be kind of daunting, but I think as long as you have a basic approach to platelet disorders, patient comes in with evidence of bleeding, usually superficial, petechiae, purpura, nosebleeds, menorrhagia, so heavy menstrual bleeding, you start thinking, is something wrong with the platelets? Check the platelet count. If it's low, it's thrombocytopenia. If it's normal, it could be platelet dysfunction. Once you get to that thrombocytopenia point, you say, okay, could it be some type of process where it's involving other cell lines? So pancytopenia, that's aplastic anemia. You got to get a bone marrow biopsy to confirm. Is it affecting red cells and platelets? So it's anemia and thrombocytopenia. Okay, a lot of different things to think about. Are they ripping up the red blood cells? Is there schistocytes? Is there increased LDH, decreased haptoglobin, increased bili? That's MAHAs. So then I got my DIC, my TTP, my HUS, right? And help. From there, if I think it's MAHAs, then I have to look at it. Is there any abnormal coagulation? All of them are thrown off. Increased PT, PTT, my fibrinogen's low, my D-dimer's high. That's DIC. If they're all normal, you're left with HUS, TTP, right? How do I know the difference between HUS and TTP? TTP, neurological symptoms, renal failure. Remember the unfortunate mnemonic, fat RN.
Right.
If it's a young child, diarrheal illness with significant renal failure, HUS. If you go back and you have anemia, thrombocytopenia, no schistocytes, no hemolysis, and they have a history of cirrhosis, think about splenic sequestration. They'll probably have some splenomegaly. And if you think about isolated thrombocytopenia, it's ITP, HIT, or antiphospholipid. With HIT, heparin exposure in 5 to 15 days, again, you expect a good drop in their platelets and you expect them to have thrombosis. For antiphospholipid syndrome, thrombosis, recurrent miscarriages, history of SLE. For both of those, you want to have clinical, but then laboratory data. So send off the tests, send off the PF4, the serotonin release assay, but DC the anticoagulation, the heparin, and start an alternative. Antiphospholipid, test all the antiphospholipid antibodies and give them anticoagulation. If you rule out those and you come to the point where a patient has isolated thrombocytopenia with no HIT, no antiphospholipid, could it be ITP? If it is, make sure you rule out secondary causes, infection, SLE, malignancy, drugs. You do that, it's secondary. If you're left with nothing else, it's primary ITP. And I think from there, you have a good idea of thrombocytopenia. If you get to the other limb, though, unfortunately, where a patient has a normal platelet count, you're left with, is it a platelet dysfunction? So you say, is their bleeding time long? You make the NIC, unfortunately, they bleed longer. Oh, okay, it is bleeding dysfunction due to platelet dysfunction. All right. From there, what do? I say, is there a ristocetin cofactor assay? If I check that and it's low, it's von Willebrand or Bernard-Solier. If it's normal, it's probably Glanzmann's thrombocythemia. Do they have renal impairment? Uremic platelet dysfunction. If I get to the point of where I'm thinking von Willebrand's or I'm thinking Bernard-Solier, what do? I check the von Willebrand factor, factor 8, and then for Bernard-Solier, I check the flow cytometry. And that will kind of take you down all the algorithm to think about every single platelet disorders that's pertinent.
It's as easy as that.
I hope so after this video. I really do.
I think it certainly helped 100%.
Awesome. Then that's a job well done by us then. Well, Ninjers, I hope that you guys liked this podcast. I hope it made sense. I hope that you were able to take a lot away from this. And whenever you are approached with any kind of a question on platelet disorders, you'll be able to destroy it and take care of it. So thank you guys so much for listening to this podcast. I hope you guys liked it. Love you. Thank you. And as always, until next time.